The next concept that we're going to talk about in the PowerPoint is bleeding and hemophilia. Looking at general causes of bleeding, the first one we're going to look at is thrombocytopenia. This is a decrease in the number of platelets in an individual. Platelets are responsible for clotting, so if an individual has a decreased number of platelets, then they will have a problem with clotting and will continue to bleed or experience excessive bleeding. Patients who are on anticoagulants have an increased possibility of bleeding. Anticoagulants obviously are meds that are used to thin the blood, and so depending on why the individual is on the medication and how often it is used and the dosage will cause a patient to be at an increased risk of bleeding. An individual who is on NSAIDs increases bleeding tendencies because NSAIDs will inhibit platelet formation, and platelet formation are needed for clotting. DIC is disseminated intravascular coagulation. DIC is very different because the individual that is experiencing DIC is actually going through clotting and bleeding at the same time. So what happens in DIC is that clots form inside of blood vessels. And when these clots form, they use up all the clotting factor in an individual's body. So then the patient starts to bleed out. So with DIC, a patient will experience clots forming inside of blood vessels, and the body recognizes that for whatever reason, they need to send extra clotting factors to where these clots are forming in these blood vessels. So when they send this clotting factor, it depletes the body of the clotting factor, so then the patient starts bleeding out. So DIC is kind of a very interesting phenomenon in that the patient is clotting and bleeding at the same time. So it's something that has to be managed very closely on your patient. Von Willebrand disease is where an individual actually has low levels of clotting proteins. So because of these low levels, they have an increased risk of bleeding. And then the last cause that we talk about is hemophilia. And hemophilia is where an individual is actually missing the factor that will contribute to clotting. So the patient is going to bleed because they don't have this factor in their blood and in their body. This is the graph that we looked at previously that talked about coagulation from the intrinsic and the extrinsic pathway. Just as we talked about this causing coagulation and a patient having a clot, these factors will also contribute to a patient bleeding because of the lack of factor and the lack of thrombin and fibrin being activated. So this is the same phenomenon. It's just that now because of the patient not having the factor and not having the ability to clot, or to form the fibrin clots, then the patient will start to bleed and will continue to bleed. Looking at assessment and lab values on a patient who has an increased risk of bleeding, obviously the first assessment we're going to see is bruising. If a patient has an increased amount of bruising, or if a patient bruises very easily, that contributes to the possibility of them having bleeding occurring. Purpura is where it looks like a rash, and actually what's happening is the vessels are actually leaking blood under the surface, and we'll look at an example of what purpura looks like. But this is a cause for concern because this means that there's actual bleeding going on under the surface. If an individual experiences bleeding during brushing their teeth, shaving, small cuts, or puncture sites, this again is an assessment indication that a patient has coagulation problems and that they have a tendency to increase bleeding. When we're looking at our lab values, we're looking at platelets. Again, we're looking at the number of platelets. So in a patient who is experiencing thrombocytopenia, this is a low level of platelets, a low number of platelets, and this will affect a patient bleeding because they don't have the platelets to have the clotting ability, so they're going to continue to bleed. Again, looking at hemoglobin and hematocrit, which is the amount of blood. And when you have a low amount of blood can become stasis, which can lead to clots, but it can also lead to bleeding tendencies also. Looking at your PT, your PTT, and your INR, these again are looking at how thin or how thick the blood is. And so if a patient has a high PT INR, then they are at an increased risk of bleeding because the blood is so thin and does not have the ability to clot. This is some examples of purpura. So you can see what this rash looks like, and this is actually where the blood vessels are, again, leaking blood underneath the surface. And you can see the different types of rashes that can look like. So this is what purpura will look like on a patient who has an inability to clot. Interventions. When we're talking about interventions for an individual who is at an increased risk for bleeding, the number one thing we want to look at, if there's patient is actively bleeding, the first thing we're going to do is apply pressure. We have to apply pressure and then go forward with our other interventions. So if a patient is actively bleeding, pressure is the number one thing we're going to do. Once we've applied pressure, then we can go on and do further actions. We can administer an antidote. So depending on what is causing the patient to bleed. Patient who is on heparin, we would then administer protamine sulfate for a patient. If a patient was on warfarin, we would give them vitamin K. If a patient is a hemophiliac and is actively bleeding, we would want to administer their factor. So the first thing we're going to do if actively bleeding is we're going to apply pressure, then we're going to administer medications that we need to help the patient stop that bleeding that they are experiencing. Then we're going to, once we've controlled the active bleeding, then we're going to treat the cause. So then we need to do some investigating, find out the reason why they were bleeding, and do further testing. And once we know what is causing the bleed or causing the patient to bleed, then we will treat from there. Hemophilia is the area we're going to look at next. Hemophilia is actually the absence or dysfunction of the clotting factors. We have two types of hemophilia that are the most common that we're going to look at. In hemophilia A, the patient is missing factor 8. So in hemophilia A, the patient is missing factor 8. And in hemophilia B, the patient is missing factor 9. In hemophilia B, the patient is missing factor 9. These factors contribute to clotting, and so having the missing factor means that the patient is at an increased risk of bleeding because they cannot contribute or they cannot control their bleeding because their blood will not clot because of these missing factors. Hemophilia is an X-linked recessive disorder. It's important when looking at genetic counseling for affected patients. We will see females be carriers of this disorder because it's an X-linked, but the disorder itself is going to be seen primarily in males, predominantly in males. So understanding, and this is the genetic chart, and you can see the X-linked recessive carrier mother, and we have two instances here of who is affected and who's a carrier. Understanding affected, unaffected, and carrier is very important when individuals are looking at how it can be passed on to their children and the instance of when they will see this in offspring. When we look at the severity of hemophilia, we look at factor activity. So factor activity is the amount of factor in the body and blood. So factor activity means that this is how much of the factor is active in the blood, and it is going to determine how severely an individual is affected by the hemophilia. Less factor activity, the more problems a patient is going to have. So in this instance, the less factor is problematic. So when we're looking at the severity, an individual who has less than 1% of factor activity is very severe. So this is a severe hemophiliac. Individuals who have 1% to 5% factor activity are at moderate risk. And individuals who have greater than 5% to 40% of factor activity are at a mild risk. And we'll talk about how this plays into giving medications and how this plays into daily lifestyle for patients in further slides. But again, factor activity is the amount of factor that is actually going on in the body. And so less factor is going to create more problems for an individual. So when we're looking at clinical manifestations, again, what is going on with the patient is going to be dependent upon the severity of how the patient is affected. So if you have an individual, if you have a patient who has a severe disease, so that is less than 1% of factor activity in their body, these patients are going to get spontaneous bleeds. These are patients who can be sitting on a couch, no one around them, not doing anything, and they can start to have a bleed. Or they could have someone brush against them. They could have something brush against them. Doesn't have to be hard, doesn't have to be a trauma or anything. They can just be walking by and someone brush up against them, bump into them, and they have a severe bleed. And they are going to have a spontaneous bleed. This is a severe problem. These are patients that have to be very closely monitored. A patient with moderate severity, so that's the 1% to 5% of factor activity, they are going to bleed with trauma. And by trauma, we mean, so these are the individuals who are now going to have, if someone hits them, or if they hit a part of their body on something, they bump into a door, they hit their knee on a coffee table, they run into something, someone opens their car door and hits them. This is where they're going to experience a bleed. So there has to be some kind of trauma. They fall, there has to be some kind of trauma, but they are at a higher incidence of bleeding with those smaller amounts of trauma. An individual with a mild severity, so this is greater than 5% to 40% of factor activity, these individuals are going to usually bleed with severe trauma. So we take it up a next step. So this is an individual who is going to fall off a bike, or an individual who is not, is going to fall from a greater height. So falling off of the couch versus rolling over, on the floor. Patients who have surgery. This is that, you have to actually have a wound, a puncture for these individuals to bleed. Okay? So again, the severity of the disease is going to be dependent upon how the patient bleeds. We're looking at symptoms related to the location of the bleed. So when you're looking at clinical manifestations, you're looking at where the patient is actually bleeding from. When you look at neck, mouth, and the thorax, this is where we're concerned for airway. So individuals who have any bleeding in the neck, in the mouth, or in the thorax region, we're very concerned for the airway. So we're going to want to ensure that we're going to want to ensure that they have a patent airway, because it doesn't take very much, especially on a patient who has a severe level of disease. a little bit of bleeding into the mouth, and they could have a compromised airway. So it's very important that we're keeping that airway open. When you're looking at a patient who has an injury to the head, first off, remembering that scalps bleed very heavily. So if you've ever had someone fall, or if you've ever seen someone who came in with a scalp laceration or a head laceration, those tend to bleed heavily anyway. The scalp area is very, has a lot of blood vessels, and so those are going to bleed heavily anyway. But in the head area, the scalp with an individual who is a severe, has a severe hemophiliac, those are really going to bleed, and we're not going to be able to stop those. So again, the scalp bleeds heavily, but we want to watch closely for that. The other thing we're watching with the head is level of consciousness. So again, just sometimes if you have an individual who has got a severe, is a severe hemophiliac, they can lay their head down on a pillow, and if they lay it down too hard, they can actually cause their brain bleed and can actually lose consciousness from this. So in the head area, we're looking very close at level of consciousness because we're concerned for brain bleeds. When you're talking about assessing, one thing that you want to look at, especially on a hemophiliac, is I'm going to be very concerned about an individual who has fallen. Did they hit their head? Because I may not be able to see a bruise if it's a deep brain bleed. If it's under the skull, it may not actually bruise up, but they could have a brain bleed, a bleed going on in the brain that we are unaware of. So that is something we're going to be watching for. When you're looking at the abdomen is a very large space. A patient can have a bleed into the abdomen and not display any outward signs at the beginning, and can lose a lot of blood into their abdomen and then have further complications because of the large amount of blood that can be lost into the abdomen and the amount of time that it may take for them to, for symptoms to actually appear. So when you're looking at a patient who has the possibility of a bleed into the abdomen, one of the areas we're looking at is your H&H, because if your patient keeps dropping their H&H, their hemoglobin and hematocrit, and they have a cause of anemia, we're going to look at the abdomen, because the abdomen can hold a lot of blood, and the patient may not have symptoms, but they could be bleeding into the abdomen. Looking at the spinal column, the patient can actually have a spinal column bleed, and it's going to take a little bit of time, and it will fill up that spinal column. And usually a symptom that's going to manifest from this is going to be some numbness and tingling, or even going as far as paralysis, because that bleeding is involving the nerves of the spinal column. So it may start out with some numbness and tingling and actually move on to paralysis for your patient. Joint bleeds. Your patients who are hemophiliacs or have a bleeding disorder have a high incidence of joint bleeds. And sometimes this is very hard to recognize and hard to see in a patient. Subjective feelings are the most important. An individual who has a bleeding disorder, they know when they're bleeding. They know, especially if it's an individual as they get older and they've been dealing with this condition, they're going to know. So the subjective feelings are most important. When a patient tells you that they are starting to feel some stiffness, some tingling or ache in those joints, and this is not something that they have had previously, or it's new onset of symptoms, that's when we need to listen to the patient, because there could be a bleed going on in that joint. The objective symptoms may not be present for hours after it starts. So then when you're seeing the objective symptoms, so what you can see, the warmth of a joint, the redness, the swelling, or severe pain because that joint now has so much blood in it that it's causing severe pain from the pressure for the patient. Those are not going to be present for a while after, can not be present for an amount of time after the bleed has actually started. So it's very important, especially in your hemophiliac patients, that if we've got a bleed, we factor into these patients. And so when an individual tells you, we need to listen. Listen to the patient, as they will know the signs about bleeding before they actually sometimes present with outward signs, with those actual manifestations. So how are we going to treat our patients with hemophilia and with bleeding conditions? Like we talked about previously, apply pressure. We have to apply pressure first. It's not going to do any good if your patient has an active bleed and they're bleeding out of an extremity. So the patient is a hemophiliac, they cut their arm and they've got blood coming out of their arm. It's not going to do us any good to give them the factor if this blood is continuing to come out of their arm. So we have to apply the pressure first. After we apply a pressure, then we're going to administer factor. That becomes a priority. When we're talking about hemophiliacs, remember, they're lacking in that factor, so they can't clot. So we can sit there and hold pressure for 20 minutes, but the minute we take our hand off or the minute that pressure is removed, if we haven't administered factor, then they're still going to start they're going to continue that bleeding. So the first thing we're going to do is apply the pressure, and then we're going to administer factor to these patients. In an individual who's got active bleeding, we want to then do RICE. This is going to help decrease inflammation. It's going to help bleeding stop. So we're going to rest that area, rest the joint, rest the extremity, whatever it is, we're going to rest it. We're going to ice it to decrease that inflammation and to help that coagulation process. We're going to put on compression, so whether that be a compression bandage to help with pressure, or some kind of wrap, a compression wrap, to help decrease that inflammation also. Then we're going to elevate it. Depending on where it is, upper extremity or lower extremity, will depend on where we're elevating, which appendage we're elevating. But you're going to want to rest, ice, compression, and elevation. Nursing implications. So what are we going to teach our patients? What are we going to educate our patients on? Avoiding NSAIDs. Again, NSAIDs are going to increase bleeds. So if you have a patient who is already prone to a bleed, or a patient who is already at high risk for a bleed, we want to help them avoid and educate them to avoid NSAIDs. We're going to want to ensure that they are exercising safely. We don't want them to become sedentary, because then we're going to have other complications. We want to keep them active, but we want to ensure that they're practicing safe exercise. I will post in Canvas a link to what is safe. It's called Playing It Safe. And these are sports and activities that children and young adults can partake in if they are a hemophiliac. And thinking about, what is going to cause the least problems, for the exercise. There are some exercises that are absolutely forbidden. If you've got a patient who is a severe hemophiliac, they're not going to be doing anything, hardly anything, exercise-wise. They can still do things, but even your moderate hemophiliacs, they can do things, but they still have to be very careful. And then your mild hemophiliacs, they're still having to be careful, because there's still that possibility that in a high trauma, a severe trauma, can trigger a bleed for them. So again, I will post that under Canvas. It's called Playing It Safe, and it goes through the different types of activities that an individual can do. When you're doing range of motion with your patient, you always want to make sure that your patient is doing the active range of motion. Patients should never, and nurses should never, do passive range of motion on an individual who's a hemophiliac. We can actually trigger a joint bleed because of it. So the patient performs the range of motion. They know what they can do. They know what feels okay. They know what's not going to cause pain. And again, we always want to ensure that patients are doing active range of motion, not passive. Passive range of motion means that the nurse or PT or OT does the actual range of motion for them. We do not want to do this in a patient who's a hemophiliac. They should be doing active range of motion. Educating. We're going to teach family about factor administration. Family and caregivers are going to be the ones at home that are going to give factor. So we want to make sure for our patients that are hemophiliacs that the family knows how to administer factor. We want to make sure that they have factor at home with them at all times. An individual who is a hemophiliac, if they get a bleed, they may not have enough time to get to the hospital and have the factor administered before they have a very serious complication from this bleed. And again, it depends on where the bleed is at and what is happening with the bleed. But the patient at home is going to have the factor. A patient who is a severe hemophiliac, and we'll talk about factor administration on the next slide. But an individual who is a severe hemophiliac is going to have factor every day. That's just the way it's going to be. But again, even the mild hemophiliacs will sometimes need to have factor administered at home. So educating the family on how to give the factor, storing the factor, ensuring that the factor is on hand is very important. Preventing bleeding. We're going to, again, talk to our patients about preventing bleeding. So how are they, not using the razors, the straight edge razors? Making sure that, when you're brushing your teeth, you're using a soft bristled toothbrush. Anything we can do to treat them to prevent bleeding. Being careful when they are, using knives to cut things. When they're outside and they are doing things outside, making sure that, if they're gardening or weed whacking, that they're not getting cut with anything like that. Just anything that we need to teach the individual on about preventing bleeding. Immunizations. Yes, individuals that are hemophiliacs will get immunizations. It's important that they get the immunizations. Where we're looking at with immunizations is it has to be scheduled that the factor is given before the patient gets their immunizations. So we're going to ensure that if an individual is due for an immunization, we're doing it on a day that they're getting their factor. We're going to limit the number of immunizations. So we don't want to give, a lot of times when immunizations are given to babies now, they're given 3, 4, 5, and 3 or 4 immunizations. And it's, they come in for one visit, we give them all their immunizations and they're on their way. With a baby who is a hemophiliac or with an individual who's a hemophiliac, we're going to limit the number that are given at once. So we're going to spread those days out. So they won't get all of their immunizations on one visit. They will be spread out over multiple visits. We're also going to ensure that we're going in a different extremity. So we'll schedule the patient to come in on a Monday. We'll give the factor. They'll get the immunization in the right thigh. Then the following week, we will schedule them for their next immunization. We'll give factor. Then we'll do the immunization in the left thigh. So we're rotating sites, and we're also making sure that we're not doing more than one immunization on a day. Women's issues. When women are on their menses, we need to increase their factor. And again, this depends on the severity. So the severity of the individual with their hemophilia. But when when a woman is on their menses, we are going to have to increase the factor. And that is just going to come from, how often that factor is given and the severity, again, the severity of the individual. But these are all nursing implications, and these are all things that we're going to have to educate our patients about, and things to think about when a patient becomes or is identified as a hemophiliac. When we're looking at factor administration, factor is administered for different reasons. As we discussed, hemophilia A and hemophilia B patients do not have factor in their blood, so we have to give it to them. When an individual has on-demand factor administration, We are giving this because they have a bleed occurring. We could also give it if we know there's a time that they're going to anticipate a bleed in the instance of surgery or immunizations. So on demand means that a patient actually has an active bleed going on, and so we're giving it to them to counteract that bleed. Or we have an individual who is going to experience a bleed. They're going through surgery, they're getting an immunization, and so they have to have that factor to counteract that. A patient who's given prophylactic factor administration is your severe hemophiliacs. These are individuals who are getting regular administration of factor. And in your severe hemophiliacs, they will get factor 3 times a week. It's always given. And then if we have an individual who has a bleed on top of that, then they would become on demand. But prophylactic is for your severe hemophiliacs, and in some cases, your moderate severity hemophiliacs that are given factor on a regular basis at the same time. Factor can be given at home or it can be given in an infusion center. It just depends on the individual, it depends on their resources, and it depends on insurance. We need to ensure that if it's given at home, family is educated on administration. We need to ensure that family understands how it should be given, how it needs to be stored. IV, it's usually given IV push over 3 to 5 minutes, depending on the amount that's being given. Patients will usually have a Mediport if they are severe and need to have regular administration. Or sometimes, depending on how the family is trained, we can just give it through an IV, through a peripheral IV, where they'll just kind of do, it almost looks like a reverse blood draw, where they just insert a small butterfly needle into a vein, and then it's given through the IV that way. Understanding the half-life of factor is very important, especially for individuals who are severe, and we need to know how often to give it. If an individual lacks factor 8 has an half-life of 8 to 12 hours, and half-life, again, remember, is that the medication drops by half in the time after it is administered. So if an individual has to be given factor 8, that means that the individual will have full coverage for 8 to 12 hours, and then it will drop to half. Factor 9, the half-life for factor 9 is 18 to 24 hours. So this is important when you are giving on demand before like a procedure or immunizations, because it's very important that it's given at the appropriate time. You don't want to give and you don't want to give an individual factor 8 at a certain time and then it go outside of the half-life and then they have their procedure done, because then the factor is not going to work for that individual. So understanding the half-life is very important because it helps to discuss with administration and when they are actually getting the factor for on demand. The other thing we look at is the expense. Factor is very, very expensive. If you have taken care of a hemophiliac in the medical center, you'll know that we don't waste any factor. We will dose factor according to a patient's weight, but we will ensure that we're giving the right amount of factor without wasting any of the factor, because factor is very, very expensive. It's very important that individuals only keep on hand enough factor that they need that's not going to expire. As I've said, it's very expensive. A patient who's a hemophiliac, in 2017, it was estimated that their medications could cost anywhere from $270,000 to $300,000 a year for their factor. In 2017, the U.S. hemophilia drugs sold between private individuals, so patients, and to hospitals was $4.6 billion. So that gives you an idea of how expensive hemophilia is. I'm sorry, of how expensive factor is for your hemophiliac patients. So again, very important that they're understanding the correct use of factor, how it's supposed to be given, and how it's supposed to be stored, and the importance of these individuals getting the appropriate amount of factor. Long-term considerations. When we're looking at long-term considerations for hemophiliac patients, development of inhibitors. So an individual can actually be given factor so much that the body will begin to develop inhibitors against the factor. So that is why it's important that when you're talking and doing education with your patients, they know about the things they can do with their hemophilia, what we're monitoring for, what the family needs to be monitoring for, what the patient needs to be monitoring for, and that they get the appropriate amount of factor. Because if they're given too much factor, the body can develop inhibitors. You may see muscle atrophy in patients who are hemophiliacs, and this can be due to joint bleeds, because when an individual has a joint bleed, they're not going to want to move those joints. And so if it's something that happens on a regular basis, you can actually see some muscle atrophy happening because the individual is more bedbound and they don't want to move those joints, and they don't want to move because of the pain from the bleed itself. Patients with, again, with the joint effusions can have arthritis or chronic pain. And again, that's due to the joint bleed, due to some of the joint effusions and some breakdown happening. We have to be concerned because these hemophiliac patients receive a lot of blood transfusions. So it was very concerning before 1985 that patients were at higher risk for HIV and hepatitis in blood. Blood is very closely now screened. It doesn't mean that it can never happen, but now with the high incidence of screening and the more technical screening that is done on blood, it does have a decreased risk. But again, it's something to think about to monitor on your patients, your hemophiliac patients, because they are going to get a lot of blood transfusions. We talked about genetics playing into it, and so genetic counseling is very important as these individuals grow up and want to become parents, to understand what the risk is of being a carrier and passing it on to their offspring. So genetic counseling is also going to be very important. Again, as we talk about with everything, education and support is going to be very high with your hemophiliac patients. Support groups, ensuring that they have the support of other families, have the support of someone to talk to. Again, anytime you have a long-term disease, having support and being able to have an outlet and having someone to talk to is very important. This is the same thing with hemophiliac patients. Understanding the disease and having someone else to talk to that has the same disease. While every disease is not the same, you still have individuals that are going to be going through the same thing. So making sure that you're providing resources for these individuals, you're providing education, you're providing the support that they need during these times. Again, I will be posting some NCLEX questions in Canvas, so be looking for those. I'll post a PowerPoint that has some NCLEX questions. But if you have any questions on either bleeding and hemophilia or clotting, you can always email me. Have a great week.